Now we are coming for the last lecture for today for Dr. Hassan Ahmed. He's lecturer of anesthesia and pain management in Cairo University. And he's going to talk about post-operative pain management in thoracic surgery. And I'm sure you will enjoy Dr. Hassan. Well, welcome, Dr. Hassan. Are you ready?
Thank you very much, Dr. Yasser. It's very much appreciated.
Go ahead, yeah.
And I would like to thank Dr. Saad as well for his enormous support. And thank you, Mega Online, for these interesting lectures. So good evening, everyone. My name is Hassan, and I'm a consultant in anesthesia and intensive care. And I'm a lecturer of anesthesia in Cairo University. Today, I'm going to talk about post-operative management in thoracic surgeries. And so this is our agenda for today. So first of all, I don't have any conflict of interest. And today I'm going to talk about the following items. First of all, importance of pain control in post-thoracic surgeries and the anatomy of the chest wall innervation and how is sensation is innervated in thoracic operations, and what is the current evidence behind, and if there are any guidelines for recommendation of pain management in thoracic surgeries or not. And I'm going to talk about the available regional anesthesia techniques for thoracic operations. So as highlighted by my eminent colleagues in previous lectures, post-operative pain management in thoracic surgeries is paramount. And it is very important to make sure that your patient after thoracic surgery is pain-free. So first of all, if you didn't manage to make your patient have adequate pain relief after operation, he will develop loads of pulmonary complications and reduced FEV1 after operations, and which would result in lung collapse and development of later on chest infections, and would prolong definitely the hospital stay and would delay the rehabilitation. There was a lot of meta-analysis about the development of chronic pain after thoracic surgery, and it was 57% at 3 months, and 47% of patients who had thoracic surgeries developed chronic pain within 6 months post-operatively. So first of all, if we want to know where is exactly, how is the nerve supplying the chest wall coming from? So chest wall innervation, it just comes from the spinal nerve, so anterior division, anterior primary mouth, the spinal nerves between T1 and T11. And it will go between, so come from the intervertebral foramina and then pass between the posterior intercostal membrane and the internal intercostal muscle, and then it will go between the innermost intercostal muscle and the internal intercostal muscle till it reaches the mid-axillary line. It will give the lateral cutaneous branch, which penetrates the muscle to supply the skin, and then will continue till it reaches the front to become the anterior cutaneous nerve. Now, is the pain from the thoracic surgery come only from somatic innervation? Well, the answer is no. So there is some innervations as well, like pleural innervation, lung innervation. So the mediastinal pleura is supplied by vagus nerve, diaphragmatic pleura is supplied by phrenic nerve. So all of the visceral pain will contribute to the pain after operation as well, additionally to the somatic pain. Added to this, which would contribute to a major pain after operation, is the muscle traction during the operation, the rib separation, and it could result from even from the sutures, the surgeon who try to approximate a post reps by either sutures or wires. So all of this would contribute to post-operative pain after thoracic operations. So if we would like to talk for regional anesthesia in thoracic operation, we can block the nerves here. This is the first site you can block your nerves in, which is paravertebral block. The second side you can block your nerves here is erectorospinal block, and you can do some lateral chest wall blocks, which is serratus anterior block. In another occasion, like in cardiac operation, you can block here anteriorly, do some blocks, parasternal block like pectointercostal block or thoracic anterior muscle plane block. So is there any available guidelines? Is there any available recommendations for post-operative pain management following thoracic surgery? So this guideline was published in 2019, and they have developed guidelines for enhanced recovery after lung surgery. And this was done by Enhanced RAS Society and the European Society of Thoracic Surgeons as well. and they have developed 45 items of ERAS to enhance the outcome after thoracic surgery. If we look at the perioperative analgesia and the perioperative pain management, what's the recommendations? So they recommended that regional anesthesia, and they said it's essential, and they recommended paravertebral block, and they said it's almost as efficient as the epidural. They recommended the routine use of non-steroidal paracetamol, and they recommended the use of ketamine, either bolus or an infusion if there is a pre-existing chronic pain, and they recommended dexamethasone as well. And they gave us a home message, which is usage of systemic multimodal perioperative care pathway is essential to improve recovery after thoracic operations. This is the recent guideline, or the most recent one actually, for pain management after VATS. This is for video-assisted thoracoscopic surgery. This has been developed by the Postoperative group, and the Postoperative is a procedure-specific pain recommendation for pain management. And this is endorsed, this is actually developed and endorsed by the European Society of Regional Anesthesia. This has published this year, and they have few recommendations for pain management after VATS or video-assisted thoracoscopic surgery. So how they develop these guidelines? The Postoperative group methodology for this is they do a systematic review for all of the randomized controlled trials, all of the meta-analysis available, which is studying the post-operative pain in thoracic surgery. And they have concluded that, so after the whole survey, they found that there are 71 studies, and they include 69 of randomized control studies, and 2 were systematic reviews. So after they have checked all of these studies, they come up with some recommendations, and then after they have these recommendations, they rotate these recommendations among a group of experts in regional anesthesia, and they vote on it, and they achieve a consensus, use the modified DELPHI methodology, which contain anonymous voting on a couple of rounds, and they come to us with the recommendations. So what they have recommended, first of all, I will tell you what they didn't recommend because of lack of evidence. Well, they didn't recommend in the pre and intraoperative periods, they didn't recommend gabapentinoids, they didn't recommend corticosteroids, they didn't recommend magnesium sulfate, intravenous lignocaine, and transcutaneous electrical nerve stimulator, wound infiltration, intrapleural analgesia, intercostal nerve blocks. And they advise against thoracic epidural because they considered it pretty invasive, which associated with a lot of complications like hypotension, urine retention, and well, if the patient is an anticoagulant, it carry higher risk as well. And there is availability of more safer options like paravertebral block, electrospiny, and serratus anterior. In post-operative period, they didn't recommend gabapentinoid, they didn't recommend intravenous lignocaine, dexamethasone, neither the TENS. So what did they recommend as grades between A and D? So for this recommendation, they have just to check the evidence they collected, and they graded according to the quality of the evidence collected. So in the pre and intraoperative periods, they recommended routine use of paracetamol, non-steroidal, dexmedetomidine. They recommended it in case you won't be able to give a POC. And in post-operative period, they recommend to continue on paracetamol, COX-2 inhibitor, or non-steroidal, and they recommend opioids only as a rescue analgesia. When we come towards the regional anesthesia techniques recommended by this group for post-operative thoracic operations, they recommended for grade A paravertebral block either a single shot or a continuous infusion, and grade B erectorospinal block either single shot or continuous, and they recommended grade D the serratus anterior plane block either single shot again or continuous. The Postoperative group have published guidelines for management of pain in thoracotomy patients, on thoracotomy surgeries. This is pretty old, it's 7 years old. This is published in 2015. And they have published an algorithm in which they recommended that we can use in thoracotomy patients paravertebral or epidural, and both of them as a continuous infusion. And if we are not able to do any of the epidural or any of the regional anesthesia techniques, they recommended to go for IV opioids, IV PCA as opioids, and they recommended the routine dose of paracetamol and non-steroidal. Again, this is pretty old. This is 7 years old recommendation for thoracotomy, and I believe it would be reviewed because there are a lot of emerging data which detecting the efficacy and confirming the efficacy of the paravertebral block and erectrospinal block, and to lesser extent the serratus anterior block. Now, if we are going to check what are the regional anesthetic techniques for thoracic surgery, if we are going to classify them, there were posterior chest wall blocks in which we have paravertebral block and erectrospinal block, and for lateral chest wall blocks we have serratus anterior plane block. So first of all, if we are going to touch base with all of these blocks, so paravertebral block, if we are going to talk and speak about the paravertebral space, so the anatomy of the paravertebral space, it's bounded medially by the vertebral body and the intervertebral foraminae, and anterolaterally, as you can see, by the pleura, and posteriorly by the costus transverse ligament and the internal intercostal membrane. The contents of the paravertebral space is anterior and primary rami of spinal nerves, rami communicans, sympathetic chain, and adipose tissue. So if you can do the paravertebral block either blind or by ultrasound. However, with ultrasound will give it more accuracy because you can accurately see where is the tip, exactly where is the tip of your needle and where is your local anesthetic is going rather than blindly. If you are going to do landmark technique or blind technique, so you will feel the spinous process at the desired level. We usually go between T4 and T5 for a thoracotomy or 4 VATs, and you feel the spinous process and you go 2.5 centimeter lateral and you go with your needle. You will hit the transverse process and either slip your needle above or below the transverse process. You will feel loss of resistance. You can use the Tuhi needle to achieve this and inject your local anesthetic. So this, again, the landmark technique or the blind technique, you feel the spinous process and then go 2.5 centimeter laterally and you will feel the transverse process. You can do it at single level and you can do it at multiple levels. Some centers doing it at 2 levels actually. Okay, but I do it myself at single level and I got a very good results from it. In terms of if you are going to do a paravertebral block with ultrasound, there are 2 techniques for it. Either you can do it in plane technique, you can do it out of plane technique. And in the in plane technique, as you can see that picture at the bottom left of the screen, you can see, so put the probe sagittally parallel to the transverse process. And I'll show you an image now for the paravertebral space, or you can put your probe in a horizontal position, okay, and you can go your needle in plane. And as I told you, there is another technique which is out of plane. So this is an ultrasound image. When you put your probe horizontally over the patient back, you will find the transverse process. You'll find here is the rib. If you slide your probe just below or above the rib, you can see easily your paravertebral space. And the idea of it is just to go with your needle to penetrate the cos-transverse ligament, okay, in the paravertebral space. And when you inject your local anesthetic, you will find your pleura just going down very nice and easily. At this point, you make sure, so this is the exact sign that you make sure that you are in the right spot when your pleura just moves down with the local anesthetic spread. Now, this is the sensory innervations, the dermatomes covered when you give your paravertebral block between T4 to T5. And this is the myotomes, which is covered by the paravertebral block at this level. And these are the osteotomes, which are covered by the paravertebral block at this level. Now, however, the paravertebral block is considered minimally invasive and less invasive when you compare it to the epidural block. However, it still does have some complications. So one of the most important complications of paravertebral block is pneumothorax because you are very close to the pleura. So it's definitely reported pneumothorax. Second complication could be failure, hypotension, Horner syndrome, which is causes myose and hydrosis, because you block the sympathetic chain. So if you give bigger volume, it will spread to the cervical sympathetic chain and cause Horner syndrome. And one of the complications of paravertebral as well is epidural spread, intrathecal spread, and definitely with any block, systemic toxicity. If we want to visit what is the evidence and the current evidence supporting the paravertebral block, this is a systematic review and meta-analysis about the efficacy of the thoracic paravertebral block for thoracoscopic surgery. And they started by screening 500 studies and excluded the duplication. And they assessed nine full articles for eligibility. It's a small systematic review. It only included 6 articles about paravertebral block, but they have concluded that paravertebral block is superior to the patient group who only have opioids in terms of the pain score within 6 hours. And as you can see, this black rhomboid is just going to the left, which is favoring the paravertebral. And in the bottom part of the screen, you will see this black rhomboid just as well moving to the left, favoring the paravertebral in terms of opioid consumption within 48 hours. And here they have concluded that the paravertebral block is associated with less hospital stay when you compare it to the opioid group. And they conclude in this systematic review that thoracic paravertebral block is very important and is very superior to opioids in thoracoscopic surgeries. The second block which we are going to talk about today is erectorospinal block. So erectorospinal plane block has been started to gain popularity in the last 6 or 7 years, has been recently introduced to the field of regional anesthesia in 2016, and is gaining a lot of popularity in thoracic operations, in breast surgeries, and even in rib fractures and trauma, because it's easier to do and pretty, if this is a correct term, it's pretty straightforward and more safer to do in paravertebral block. We'll talk about it just now. So erectorospinal block, it's very easy. So all what you have to do, put your probe in the patient package in a sagittal orientation. You can get to the transverse process, and all what you have to do is to go in plane with your needle and head the transverse process at the desired level. So all what you need to do is just put your needle over the bony surface of the transverse process. And when you hit a bone, just aspirate and put your local anesthetic. Usual volume injected between 30 and 40 ml of local anesthetic. And your sign here to make sure that you are in the correct point is you will see the erectorospinal muscle just opening a very decent plane and lifting up all of the erectorospinal muscles. So if you get this nice spread of the local anesthetic above the transversal process, lifting up all the erectorospinal muscle, you know that you are in the correct space. The problems with this block, if you cannot put your needle at the correct spot and you put your needle somewhere in the erectorospinal muscle, you won't get this nice spread in the correct level plane. And I guess this is the problem with all of the facial plane blocks. It sounds easier to do, but however, to put your needle tip in the correct plane might be sometimes tricky. So, well, initially you can put your needle and you sort yourself in the correct plane. However, when you inject, you get like an elliptical spread, which you are basically injecting in the muscle. And at the end, your block won't work. So to make sure your block is working, just head the bone, head the transversal process. Your needle is not going anywhere. So, and inject your local anesthetic, you will find the very nice spread, lifting all of the erectorospinal muscle. And because you are really directing towards the bone, so it's here, it can be more safer than the paravertebral block. So the benefits of the erectorospinal block, it's relatively easy block to do and could be performed in a setting or lateral position. And you will get basically no change in the mean arterial pressure at all. And it does have lower risk of complication anticoagulated patient because you are away from pleura, so there is no risk of pneumothorax. Okay. However, if you can't visualize your needle here, will invite problems. So you should visualize your needle all through till you hit the transverse process. The drawbacks from the erectorospinal block, initially when it was developed in 2016, no one knows where is the local anesthetic is going. There were some theories that the local anesthetic is going to the paravertebral space, and others say, well, local anesthetic is just because systemic absorption, so that patient will get analgesia. So we didn't know where is the local anesthetic going. So if you inject in the paravertebral space, you know at this point your local anesthetic is filling the paravertebral space. But in erectorospinal block, it was not pretty clear where is your local anesthetic is going. So this is a very nice and recent study which was done by Kijan Chen et al., recently published in the Canadian Journal of Anaesthesia last year. And they have done a systematic review for all of the experimental studies, animal studies, and even cadaveric studies to know what is the mechanism of action of electrospine, where is the local anesthetic actually going. And they have concluded that based on the evidence they collected from human, cadaveric, and animal studies, they concluded that the main mechanism of action of electrospinal block is the direct effect of the local anesthetic via spreading through the neural structure in the facial plane deep to the electrospinal. So, and there was no data to support, well, main mechanism is going to the paravertebral or systemic absorption. So it's mainly by direct spread of local anesthetic to the neural structures deep to the electrospinal muscle. Now, what's the evidence behind electrospinal block and how effective it is in thoracic surgeries? This is a recent systematic review published in the Journal of Clinical Anesthesia 2 years ago about the efficacy of the electrospinal block in thoracic and breast surgeries. And they have concluded and they have found that paravertebral electrospinal block is superior to the no block group in terms of 24 hours morphine consumption after operation, and they found it's superior in the overall even cumulative opioid consumption. Now, the third block which we are going to talk about it today is the serratus anterior plane block, and it's considered one of the lateral chest wall blocks, and it's easy to do as well. However, because the spread of the because the spread of local anesthetic only will spread in the plane just between the latissimus dorsi and the serratus anterior block, so it won't cover much dermatomes as if you're given like posterior chest wall blocks like paravertebral electrospinal. So first of all, I'm going to speak a bit about what is the technique of the serratus anterior block. So you will put your probe at the mid-axillary line, so you will find the latissimus dorsi, and then the serratus anterior and below is the reps. And your aim is to put your needle in plane between the latissimus dorsi and serratus anterior. This is a superficial technique of serratus anterior, and it's safe to do superficial one. However, there are some techniques of deep serratus anterior plane block, is just to go with your needle, passing through the serratus anterior, and to inject the local anesthetic between the serratus anterior and the intercostal muscles. So safest way to do is just direct your needle through aiming to head the rep, and whenever you head the rep, aspirate and inject. One important structure to take care of while doing the serratus anterior block is the thoracoacromial artery, which is between the latissimus dorsi and serratus anterior. So it's recommended to put a color before you inject, so at least you can identify any vascular structure. I do mix between, like I do combined superficial and deep serratus anterior plane block. So I inject some local anesthetic, 15 ml between latissimus dorsi and serratus anterior, and between serratus anterior and intercostal muscle deep to the serratus anterior. Another 15 ml of local anesthetic should be okay. One of the problems of the serratus anterior block is it won't cover visceral pain, so it only will cover somatic pain, and it won't have a big distribution in comparison to paravertebral block and electrospinal block. And it might not cover for the chest drain position if it had only limited spread. Excuse me. So it does have a variable spread of local anesthetic, and as well, there is a limited evidence which would support the serratus anterior over the paravertebral and electrospinal block. So if we have a look on the evidence available for the role of serratus anterior plane block in thoracic operations, this is a systematic review which was published in Anaesthesia Journal 2 years ago, and they were checking the literature about the efficacy of the serratus anterior plane block. So they screened a lot of studies, like 1,000 studies, and end up by analyzing 40, so non-randomized was 42, and randomized were none studies. And they have concluded that it's still advantageous to do serratus anterior plane block in thoracic operation. However, there is still a limited data and a limited research to support the efficacy of serratus anterior plane block over available paravertebral and electrospinal block. So there are still a field for clinical trials to support the evidence behind stents and tuberculin block in thoracic surgeries. So for take-home message today, multimodal analgesia is essential for enhanced recovery after thoracic surgery. And please do any regional anesthesia technique, whatever you master, whatever you handle, for each thoracotomy or each VATS, do at least one regional anesthesia technique. Thank you very much.
Okay, thank you very much, Hassan. It's very interested, and I wanted to ask you what you are doing exactly in your daily practice. Tell me 1, 2, 3, 4 from starting, or even before starting for anesthesia till the post-operative. If you want to guide me,
yeah.
Or guide
well, I use
1, 2, 3, 4. Yeah.
I use for thoracic surgeries. I use opioid-free anesthesia, and it's a kind of debatable technique nowadays. But this is my usual practice in thoracic surgeries. So I use opioid-free anesthesia for induction, and then whenever I do the induction, I turn the patient on the side, and then I do the fastest technique which I master, which is electrospinal block. I do single shot electrospinal block at one level. I inject a 30 ml of levobupivacaine or bupivacaine, 0.25%, and I hardly.
Which type of regional anesthesia you are using?
Electrospinal block.
Okay, yeah, okay, yeah.
And I give it only at single level. I give 30 ml of local anesthetic, is the bupivacaine or levobupivacaine, 0.25%, and I never use any kind of opioid during the whole operation. And usually the surgeons put a paravertebral catheter if they are going to do thoracotomy, or they do intercostal nerve block at the end of the operation. And in recovery, patients might need some morphine PCA, but well, it's very, very, very minimal. This is my usual practice.
Yeah, maybe as an anesthesiologist, you are not following the incidence of chronic pain after thoracotomy or mini thoracotomy. You mentioned that it is around 50% or even more in some studies. Do you have some idea from your cases, there is a patient with chronic pain or no?
Well, to be honest, I hardly follow them for 3 or 6 months afterwards. But I get complaints from the surgeons about developing chronic pains afterwards. And to be honest, if patients, even if they have paravertebral, it reduces the chronic pain, but it wouldn't eliminate it. And there were recent studies even comparing the incidence of chronic pain between patients who have thoracoscopic operations and who have thoracotomy. And they found these are kind of comparable incidence of chronic pain comparing both techniques.
Okay. Also, maybe you mentioned about the prospect guidelines, which was published in April 2022.
That's right.
You mentioned, yeah. I think there is 5 basic recommendations in these guidelines to use the local anesthesia, either paravertebral block or erectorospinal plan block. Systemic analgesia should include paracetamol and non-steroidal, and to continue eat intraoperative, and to use intraoperative dexmedetomidine. Opioids can be used to resuscitate analgesia postoperative, and they didn't recommend thoracic epidural. What do you think about the thoracic epidural from your job?
Well, I think we have now available safer and less invasive, effective procedures like paravertebral or erectorospinal block. So why do I have to go for a thoracic epidural and avail all of the hypotension and urine retention and all of the systemic problems? It's more invasive, actually, when I have a less invasive and more practical and efficacious options like paravertebral or erectorospinal block.
Yeah, okay. The last comment from my side, these prospective guidelines, the second author is resident working in Belgium, and he wrote it with 2 professors. So everybody can be included in the international guidelines.
Yes.
Okay,
yes.
Thank you very much, Hassan. Maybe
you are very welcome.
Yes.
Dr. Yasser, there is some question in the chat box. Dr. Mahfouz Sarabi. Dr. Yasser. Hello.
Hello.
Hassan, you may take the lead. And
Yeah, I'm trying. Yeah. So Mahfouz is just asking for the paravertebral and MA heterogeneity was up to 99% one of the outcomes, which means that there is something major in the selection of the studies, including for. So what did he mean by MA? Is it what's meant by MA?
I don't know.
If you can't read one questions about the
Meta-analysis. Meta-analysis.
yeah.
Oh yeah. So for the paravertebral,
block.
And meta-analysis was up to 99%. Okay, I can display my screen again.
Dr. Mahfouz has mentioned that it is clear that the evidence is leaking and the data are heterogeneous concerning new block, but this doesn't mean no evidence, but we should wait until the evidence is clear. But I think the recommendations by the prospect, which is published in April 2022, mentioned that they can use both type of block, either paravertebral block or erector spiny block. This is the answer. And some questions about the opioid-free analgesia, Hassan, as well.
Yes. So what's the question about the opioid-free? So just to answer the question for Dr. Mahfouz, so prospect were very clear regarding the efficacy of paravertebral block.
This is correct, yeah. Okay.
Yes, so they recommend as grade A and electrospinal for grade B, and there were loads of meta-analyses about the efficacy of paravertebral and how it is as efficient as the thoracic epidural, and how it is effective in reduction of the morphine consumption and hospital stay as well. So it's very clear, very established that the paravertebral is very efficient and comparable to thoracic epidural.
Yeah.
Sorry, Dr. Yasser.
The original block is grade A, either paravertebral or erector spiny or serratus anterior.
Yes, exactly. This is the grades for regional anesthesia recommended by the prospect.
Okay, that's not very nice. Yeah. Another questions about the ERAS still recommended epidural.
Well,
but ERAS, I will just tell some point you can answer. ERAS is published in 2018, and this new guidelines prospect 2022. You can continue, right. Hassan. Yeah,
that's right. Well, in prospect still have older guidelines for thoracotomy, which was published 2015, which they still recommend thoracic epidural versus paravertebral block. However, in the ERAS recommendation 2018, they said thoracic epidural is still as efficient as paravertebral, but here we go in 2022, they advise against thoracic epidural because it's more invasive, more hypotension, more urinary retention, and they recommended other options.
All right, there is one expertise in pain, Dr. Yasser from Qatar. You want to give any comment, Yasser Reda?
Yeah, I have a comment and a question. Thank you, Dr. Hassan, for this presentation. I'm not engaged in any one of the presentation because it's my interesting area. Do you have any study? Because you know that all these guidelines, if you hear about guidelines, this means the personal expertise and personal opinion is behind because of for that guidelines change from now from anywhere. You know that you can find Canadian guidelines, American guidelines, Canadian guidelines according to many things, expertise, resources, and we have a special. You know, we started to do a paravertebral, what we don't do now. Sorry, we don't do now because we have a horrible complication, totally like and this is just published in literature and case report about the complication. And now we use an erectrospiny. Do you have any study to compare between erectrospiny and because you speak about opioid-free anesthesia and compare by paravertebral or erectrospiny? Do you have any study to show that? Especially if you have RCT between erectrospiny and paravertebral in thoracic surgery?
Well, what I have read about is where small randomized controlled studies, which found that there are more like they are pretty efficient, equal in efficiency between paravertebral and electrospinal block. But there's no like big systematic reviews and meta-analyses where all small randomized control studies which would compare the efficacy of paravertebral versus electrospiny. So, well, I can't say that there is one technique is much more superior to the other. However, this is only my personal experience and what I'm doing. If the patient is having thoracotomy, so I tend to do paravertebral block. If it is only that, so I will go for electrospiny. However, this is not evidence-based. This is only my experience, and this is only my practice, which I'm only responsible for. And only the available literature is more randomized controlled studies that we can't really change our practice based on.
Yes, thank you. Thank you, Dr. Hassan. Thank you very much.
There is some questions, Hassan, about if you are going to use opioid-free analgesia or anesthesia, how to intubate the patient without opioids? How to blunt that? Yeah.
Again, opioid-free anesthesia is a very debatable subject of our discussion and is not proved. And it's again just my practice. What I do for intubation for the patients, I use definitely propofol, and I use lignocaine, magnesium sulfate, and this usually would provide me with a very decent condition to give the muscle relaxant. And I give my muscle relaxant, and I don't experience any problems after the lignocaine, magnesium sulfate. And I give muscle relaxant, put the tube in, and then I do my block. I use analgesia as well. I use clonidine or dexmedetomidine. I use paracetamol, non-steroidal routine, and I hardly have to give any opioids during my thoracic procedures.
All right. I think in general, in most of the patient, it is opioid sparing, not opioids free. Opioid free, I don't know in thoracotomy. Can you use it absolutely opioid free?
Well, if you are sure that your block is working fine, you will not get any opioid. I didn't give any opioids. I usually give the mixture between magnesium and lignocaine and non-steroidal paracetamol. And if my block is working in the right spot, so I hardly give any opioids. However, if your block is midway or is not in the correct spot, you will definitely need opioids, definitely 100%.
All right. I think there is no more questions.